And I have the great pleasure of introducing our guest speaker, reigning from my home state of North Carolina. Dr. Christopher Kelsey is a professor of radiation oncology at Duke University Medical Center. He specializes in the treatment of thoracic malignancies and is the director of thoracic radiation oncology at Duke Cancer Institute. He earned his Doctor of Medicine degree from University of Colorado School of Medicine in Denver, Colorado in 2002 and completed residency training in radiation oncology at Duke in 2007. Welcome, Dr. Kelsey.
It's a real pleasure to be with you. I've been at Duke now for 20 years, and as mentioned, I treat lung cancers, and I give a fair number of talks around the country, but most of the time, the talks that I give are to other doctors. Very rarely do I give talks to patient groups. I have a few times in the past, but not often. And I must say, when I was listening to your stories, it was very humbling for me to hear what you've gone through, what you are going through and will go through. Kind of reminds me of a general giving a talk to generals is one thing, but when you're a general giving a talk to the troops in the field, that's very different. I feel like you're the troops in the field and I'm sort of in a room somewhere. It's just, so you'll have to forgive me for the fact that I don't know all the things that you've gone through. So I'll do my best. I'm going to be talking about radiation therapy and kind of focusing on the role of radiation, and we'll answer questions at the end. So small cell lung cancer. Here's a few peculiarities about small cell that fit into why we do the things we do with radiation therapy. First of all, small cell lung cancer is a fast-growing cancer. It grows faster than most others. And that's why in some circumstances, we treat people twice a day because we're trying to stay on top of it. We treat a cancer in the morning and a lot of cancer cells die, but those that don't with that particular treatment continue to grow. And if it's growing fast, you can kind of get behind the 8 ball. And so we'll often give the radiation therapy twice a day. And I'll actually show some studies about that a little bit later. The other peculiarity is it has a very high propensity to spread to the brain. And because of that high propensity, this is one of the few diseases that we still utilize a treatment called prophylactic cranial irradiation. This is basically where you give radiation to a brain that looks completely normal on an MRI, trying to prevent tumors from developing within the brain. Essentially, such a high percentage of patients will have small little seeds of cancer cells in the brain that if you eradicate those, you prevent actual overt metastases from developing. And I'll talk a little bit about that. A few other issues with small cell is it spreads very early. And I think that has to do with its fast growth characteristics. Only about a third of patients who are diagnosed with small cell have disease that's confined to the chest or the lymph nodes in the chest. 2/3 of patients are in that category where it's already spread to the bone or the adrenal glands or the brain, what we often refer to and what I heard is extensive stage small cell lung cancer, as opposed to limited disease where it's confined to the chest. One of the great things about small cell is it's very responsive to chemotherapy, much more responsive than many other solid tumors. It almost behaves like a lymphoma in the fact that after a cycle or two of chemotherapy, tumors are much, much smaller. So that is one good thing about small cell lung cancer. And then the last peculiarity that I'll list here is that some patients get what we call paraneoplastic syndromes. And that's basically where the cancer is secreting substances which can lead to weird problems. And the most common weird problem of all is SIADH, which refers to the syndrome of inappropriate ADH. That's a hormone that causes your body to retain water. So it basically tells the kidneys, don't get rid of water, hold on to it. And so if the body's inappropriately holding on to water, sodium levels in the blood go down because they get diluted. And that can lead to confusion and other neurological issues in patients. So it's kind of this funny thing where small cell lung cancer can sometimes affect the body in odd ways. All right, so this is sort of a schematic that I referred to a minute ago, that about a third of patients when they're first diagnosed have limited disease, where the disease is confined to the chest or the lymph nodes in the chest, and the goal is cure. We generally pursue a fairly aggressive course of therapy with a goal of completely eradicating the cancer. Now, it's important to realize that even though that may be our intent, we don't cure everybody. Unfortunately, we don't cure nearly as many people as we would like. And it's pretty common for people to relapse even after they're potentially cured of treatment. But that's our goal. And that generally involves what we refer to as definitive thoracic radiation. That would be either 3 weeks of twice daily treatment or 6 to 7 weeks of daily radiation treatments to the chest. And then sometimes we pursue prophylactic cranial irradiation. Now, in patients with extensive disease, the goal is that we're trying to manage the malignancy. Cure is still possible. There are a fair number of patients with extensive stage small cell where it's spread to the adrenal glands, the brain, where we eventually cure people. So it's possible, but that is not as common as the more common scenario where we're managing the disease. It pops up from time to time. We get people back into remission. It relapses. So we're trying to manage the disease. And then when it comes to radiation therapy, we often will give consolidation thoracic radiation, which is where patients will finish their chemotherapy course, and then we'll give 2 weeks of radiation, for example, on top of the chemo to the original tumor in the chest, trying to do our very best to get rid of that original tumor so it doesn't come back and cause problems. And then we often give what we refer to as palliative radiation. Palliative just means that we're not giving it in a curative setting. We're just trying to treat a problem. For example, if the cancer spreads to the brain, we might give what's called stereotactic radiosurgery. If it spreads to a bone, we may give a short course, maybe anywhere from 1 treatment to 10 treatments to make pain better. Sometimes patients with small cell will develop just a couple sites of recurrence, and we'll do a stereotactic treatment called stereotactic body radiation. And I'll share a slide about that. So you can kind of see these 2 different types of circumstances where the radiation is fine-tuned to balance side effects with expected benefit. Here's a patient with limited stage small cell lung cancer that was recently diagnosed at Duke. You can see this tumor in the right lower lobe of the lung indicated by the red star. And these are called lung windows on a CT scan. You can see tumors better in the lung on this type of scan. On the right is a lymph node that you can see here in the subcarinal area. So just where the right and the left main stem bronchi branch, lymph node right here. This is limited stage small cell lung cancer. And the standard of care for these patients would be 4 cycles of a doublet chemotherapy, meaning they get 2 chemotherapy drugs at the same time. And it would include either cisplatin or carboplatin plus etoposide. And generally, this is given every 3 weeks. So patients get treatment on days 1, 2, and 3 of a 3-week cycle. And then they get 2.5 weeks off. And you come back and you repeat that for 4 cycles. So 4 cycles takes 3 months to give. And then we give radiation therapy either once or twice a day for 3 to 6 weeks, respectively. So this is how radiation works. The first day that you come is a planning session, which we often refer to as simulation. This is a picture from the Mayo Clinic that I stole from the internet. So a patient would lie almost always on their back with their arms above their head, and we do a CT scan so that we can target the tumor optimally in the treatment position. And usually we'll have people have an IV placed so we can give IV contrast, which allows us to see the tumor a little bit better. And sometimes we'll even have patients drink a little bit of oral contrast so we can see the esophagus better, because the esophagus is one of the normal structures in the chest that we try to avoid. The simulation procedure takes about an hour or so, and then you go home. And it takes the radiation oncologist a few days to a week or so to do the planning on the computers, to design radiation fields that will treat the tumor optimally, but avoid other structures in the chest which could lead to side effects. The lungs, the heart, spinal cord, the esophagus, those are the big four. After the patient gets their CT scan, that gets exported to a treatment planning software system. And here's an example of this. You can see a cancerous tumor in the front part of the chest, indicated in the red, with the blood vessels just behind it. And we will literally draw out the tumor on this planning CT scan. Then staff in our department will contour out all the other structures. So the lungs, you can see the esophagus back here in orange. You can see the spinal cord in green. We contour out these important structures and then design radiation fields that will come in from all these different directions and focus and sculpt the radiation to the tumor, trying to avoid all these other structures as much as possible. And then we have these calculations that will tell us how much of each structure got how much dose, and that gives us a sense of the risks of the radiation. We know we have to keep the lungs below a certain dose, the esophagus below a certain dose. We know what we need to reach for our planning. And then a lot of quality assurance goes into play, et cetera, et cetera. And then you come back to start the treatment. And this is the machine that you're treated on. This is called a linear accelerator. The radiation comes out of the head of the machine here. It's important to note that there's no radioactivity associated with this machine. It's not like there's a radioactive rock in the head of the machine that radiates the patient. It's generated like an X-ray machine. So the radiation is generated, it exits out this portion of the machine. The patient lies on this couch that can be moved around so we can optimize the radiation delivery. These little arms on the side allow us to do imaging, including CT scans. Because every day you'll come in, we'll do an X-ray or a CT scan to line you up perfectly, make sure the tumor is lined up, and then you get your treatment. So an actual radiation treatment takes about 20 minutes. That's about 17 minutes of setup and 3 minutes of treatment. So the side effects of radiation when we treat the chest, the big three are feeling tired, which is ubiquitous because you're also getting chemotherapy, you're getting radiation therapy, people's blood counts can be low. So there's a lot of reasons to be fatigued. Coming in every single day for radiation is exhausting, I'm sure. The skin can get irritated and itch a little bit. Sometimes the skin will tan, like a sunburn or a suntan. But the biggest side effect by far is pain with swallowing, which we call esophagitis. That doesn't happen right away, but usually about halfway through a 6-week course of radiation, people will start to notice that it hurts to swallow, that you swallow food and it feels like it's getting stuck, things like that. And we have some treatments that we can give to ameliorate that so that patients don't lose weight and can continue their radiation treatment. The biggest risks of radiation are in about 1 out of every 10 people we treat, the lung gets irritated from the radiation, and you can get pneumonitis, which just means inflammation of the lung, which can lead to a cough, shortness of breath. We treat it with steroids and it goes away pretty quickly. Patients can get complications of the heart, which is a relatively newly observed phenomenon. As we've gotten better at curing patients with both non-small cell and small cell, we're recognizing that some patients that we are curing will sometimes have side effects shortly thereafter related to the treatment, which could be a heart arrhythmia, it could be pericarditis, things like that. So we're very careful these days to avoid the heart and different heart substructures. So I'm going to show a few studies, and I don't want to make this too technical, but I don't want to also just sugarcoat and be superficial about this topic. One of the issues that's been studied a lot over the years is, when do you give the radiation? Do you give it right up front? or do you give it at the end of the chemotherapy course? What's better? This study is a meta-analysis, which means you took 7 randomized trials that were conducted in the 80s, 90s, and early 2000s, and you combined all the data. And if you combine all the data, it clearly shows that giving the radiation early is best. And I think the reason is hitting that cancer hard right up front, if it's limited disease with both radiation and chemotherapy, decreases the likelihood that really stubborn clones of cancer will survive and become a problem down the road. And so we at Duke and most other places, we really try to start the chemotherapy with the first cycle of chemo. So you start chemo and radiation on the same day, or at the very latest, the second cycle of chemotherapy. But what we don't want to do is have radiation started after the chemotherapy is done, or after 3 cycles, for example, in limited stage disease. And then do you give it once a day or do you give it twice a day? This is sort of the big argument. And there's a lot of logistical issues that go into this. So I have some patients that live in Henderson, North Carolina, which is about 45 miles or so north of Durham. Well, that's super inconvenient for somebody to come down from Henderson, an hour drive, and then have to either go all the way back or all the way back down again later in the afternoon, which you have to separate the treatments by 6 hours, or come down in the morning and spend all day long and then go home in the evening. Patients who live in Durham, it's great because they'll come in the morning and then come in the afternoon. Or if they live in Tennessee, the twice a day is perfect because they're here anyway and they just want to get done and go back home. So to a great degree, we do once a day or twice a day based on what patients can do. But I really try to do it twice a day. This was a study that was conducted a long time ago, so results have gotten better. But limited stage small cell lung cancer, patients got treated once a day, which is the QD symbol in medicine, acronym, or twice a day. And the twice daily was better than once a day by quite a bit in terms of ability of the patients to be cured of their cancer. But the side effects were worse as well. So grade 3-4 esophagitis, about a third of the patients who were treated twice a day ended up in the hospital because they couldn't swallow. They had to have a feeding tube in. And so that has influenced modern treatment. Now, the issue was back in the 80s and 90s when this study was conducted, the radiation was not nearly as good as it is today. So today we have the ability to really sculpt the radiation dose around the esophagus, which we couldn't do back then. And we also are not using these big radiation fields like we used to do. It's very small, very focused, very conformal to the tumor. But twice a day was better. This was a study from Europe, 550 patients, a huge study. And patients got randomized to twice a day or once a day treatments. And these were the outcomes. The red was twice a day and the blue was once a day. And the study was not statistically significant, meaning this p-value down here is 0.14. For these curves to be statistically significant, so scientifically different, it needs to be 0.05. But it kind of shows that BID seems to be better. So I tend to do it BID twice a day. Now, another study was published in the United States. Now, this is a little bit different because they did it this twice a day for 3 weeks or once a day, but they did it for 7 weeks, 7 weeks of radiation. And this study basically showed that results were identical. So what do I do with limited stage small cell? We always try to give it concurrent with the chemotherapy. So you start chemo, we want to start radiation at the same time. We want the overlap because the chemotherapy makes the radiation work better, kind of sensitizes the radiation so you get more bang for your buck. We like to give it early with cycle 1 or cycle 2 at the latest. And I prefer twice daily if we can swing it for 3 weeks, but if not, once a day is okay also. All right, now this gets to one of the more complex things. Now, as we discussed a few minutes ago, small cell lung cancer loves to spread to the brain. And that's one of the biggest hurdles to curing patients. And it sounds amazing, but it's true. 60% of patients who have small cell lung cancer, limited stage disease, After we treat their primary tumor, it'll spread to the brain. So 6 out of every 10 people, you give radiation chemotherapy to the chest, and 60% of patients, it'll spread to the brain. And so that's when we started investigating this concept called prophylactic cranial radiation, which I like to think of, you're eradicating the seeds to prevent weeds from developing down the road. And the second option, though, is close surveillance. So close surveillance is you don't give the radiation up front, but you watch super close. You do an MRI every 3 months. And if tumors develop, that's when we will use either stereotactic radiation to treat individual tumors, or if we have to, sometimes we have to do what's called whole brain radiation, where we treat the whole brain, because if there's little spots all throughout the brain, we just have to treat the whole area. I think about as pulling the weeds once they develop from seeds. And we don't know exactly which one of these is best, but I strongly suspect that the prophylactic is better, because for the most part, you don't want cancer to come back. And you can try to save the situation by treating it once it does come back, but once it comes back, it's sometimes hard to make it go away for good. So for a lot of patients, I still recommend prophylactic cranial radiation. Now, it also depends on a few other factors. If patients are older, they tend to have more side effects from prophylactic cranial radiation. If they've had a stroke or other cranial or other CNS insult, or if they have multiple sclerosis or things like that, you have to take all that into account. If I have a patient who's 45, generally we'll recommend the PCI. If I have a patient who's 85, we would never recommend that, because just the side effects are too much. Age plays a big role. So I'm going to skip that. But if we look at the components to cure for limited stage disease, so what provides the cure? The chemotherapy provides 40% of the cure. Prophylactic cranial radiation provides 20% of the cure, and thoracic radiation therapy provides 40%. That's basically how the studies add up. So you can see that each component is important. Each component plays an important role. Now, the difference here is that the long-term side effects and the well-being of patients, long-term effects of chemotherapy are not zero. I don't want to minimize that, but they're relatively low. The long-term effects of thoracic radiation is relatively low, but the long-term consequence of prophylactic cranial radiation is high. So patients will develop memory challenges, short-term memory loss, cognitive slowing, meaning you go to balance the checkbook and you just can't do it as quickly or as efficiently as you could before. Your executive function, your ability to solve complex problems is compromised a little bit. You just have to imagine that you give radiation to the brain's not going to work quite as well afterward. So you're always trying to weigh the risks and the benefits. And do the benefits outweigh the risks, or do the risks outweigh the benefits? And sometimes that can be a delicate balance. So in patients who do not get prophylactic cranial radiation, or even if they do and they still get spots in the brain, we'll often use what's called stereotactic radiosurgery. That's where you get a one-day treatment, a very big treatment that's highly focused to the tumor. This is a patient with lung cancer with a metastasis in the left temporal lobe right here. And you can see how the radiation dose distribution is very tightly focused on this tumor. So you come in, you get a one-day treatment, and you go home, and patients tolerate that very well with very few side effects. The downside of doing radiosurgery is that you treat one, and there's about a 50-50 chance that other spots will develop down the road. Sometimes we end up doing this treatment several times to get all of the lesions that will develop in the follow-up period. Now, the other treatment that we will sometimes do with small cell lung cancer, I'll just give a case vignette of sorts. Let's say we have a patient who has extensive stage small cell. It's diagnosed in the lung, in the lymph nodes, in the adrenal gland, in the bone, and get chemotherapy, and everything goes away, which does happen. And then let's say 3 months later, we get one new spot of cancer in the lung. Do a PET scan. This is the only spot of cancer. Then we will do what's called stereotactic body radiation therapy, where we kind of do that same treatment that we did in the brain, but we'll treat a tumor outside of the brain with 1 to 5 treatments, depending upon the location of the disease. So this is called stereotactic radiation, SBRT, SABR. There's lots of acronyms. But basically, we're saying that's the one problem spot. I'm going to nail it with a week of radiation. So for limited disease, the standard of care is 4 cycles of chemotherapy with thoracic radiation over 3 weeks or 6 to 7 weeks if you do it twice a day or once a day. And then we have to manage the brain with either the prophylactic cranial radiation, which is 2 weeks of radiation, or keep a really close eye on the brain, knowing that more than likely, the odds are that we're going to find something that's going to have to be treated, ideally with the radiosurgery, because it doesn't have as many side effects, but sometimes we have to do whole brain radiation if there are numerous lesions scattered throughout the brain. Now, for extensive disease, how do we use radiation? Well, as mentioned before, chemotherapy is the most important component. And you don't just get chemotherapy, you also get immunotherapy called atezolizumab, and there's some other immunotherapy drugs. So generally, you'll start with the systemic therapy, and let's say that everything responds really well, but there's still cancer in the chest after you finish chemotherapy. Then we'll give what's called consolidation thoracic radiation. So we'll give 2 weeks of radiation, kind of a 1-2 punch at the residual disease in the chest to prevent or delay a recurrence in the lung, because when cancer comes back in the lung, it can cause a lot of symptoms. Patients can sometimes cough up blood or feel short of breath or have a cough. We really don't want the cancer to come back in the lung if we can help it. And then the other thing is we don't generally do the prophylactic cranial radiation in extensive disease, because again, the goal of therapy is to manage it. So managing it means you keep a close eye on it, and if something pops up, you knock it down. So that's where we'll do the very close MRI surveillance with stereotactic radiosurgery or whole brain radiation therapy if spots develop in the brain. And usually radiosurgery is a 1-day treatment, and usually whole brain radiation is a daily treatment over 2 weeks. And then, of course, we use radiation to treat small cell lung cancer in lots of areas. If it spreads to the bone, we can treat it there. If it spreads to the adrenal gland, we can treat it there. We can treat wherever it needs to be treated, depending upon the circumstances. So those are sort of just some introductory slides about radiation and small cell lung cancer. And I hope that was modestly helpful, and happy to answer any questions you may have.
Wonderful, wonderful. I do have some questions. If you did have, because they don't always do PCI now, but if you did have PCI, what's the recommendation for follow-up MRIs or maintenance if you did have the prophylactic cranial irradiation?
Yeah, that's a good question. And we don't really know the answer to that. In clinical practice, a lot of oncologists, if we do the prophylactic cranial radiation, will only do MRI scans under 2 circumstances. One, if a patient starts to have symptoms like headaches or nausea. Those are the 2 most common symptoms of spots in the brain. Or if the cancer starts to progress somewhere else and you want to restage and know where exactly is this cancer, where do I need to think about in terms of my next course of therapy, then we'll include a brain MRI with CT imaging of the chest or a PET scan, for example. But usually if we do PCI, we don't do a lot of surveillance MRIs thereafter, at least at our institution. There may be some practice variation around the country.
I can relate to a lot of this, but I have a lot of questions. I understand. I thought that the new protocol is to reduce prophylactic because it doesn't work. It did not work in my case. I had prophylactic brain radiation. I'm now dealing with a brain met. I've had gamma knife surgery done. It's caused me problems because now I'm having seizures and there's significant swelling on the brain. They're not even sure if the tumor, at first I was told that the tumor had significantly shrunk, but now there's so much swelling that I don't even know if they can tell if the tumor is still existing. And I've had a lot of issues with the prophylactic, with the memory loss. If I had to do it again, I wouldn't do it.
Yeah, and I sympathize with that. So prophylactic cranial irradiation remains a recommended standard of care in national guidelines for patients who have limited stage disease, who are relatively young and do not have underlying neurological challenges. Now, you bring up a few good points. So point number one is PCI doesn't prevent all brain metastases from developing. We know from clinical trials that it reduces the risk in half. So it doesn't reduce it 100%. So why not 100%? So in all likelihood, there's a lot of patients who they'll be treated with prophylactic cranial radiation, which will eradicate any little seeds in the brain. But if the cancer comes back in other parts of the body 6 months later, it can just respread to the brain at that point. The radiation does not prevent brain metastases from developing the rest of a patient's life. Now, what we don't know is whether in limited stage disease where it's a potentially curable situation, and again, studies have shown that we cure more people with the PCI. What we don't know is whether close MRI surveillance, so every 3 months you do an MRI and you treat spots as they develop, whether that will lead to the same cure rates as PCI. We just don't know. That study has been proposed. It's actually underway right now. There's a study around the country that is enrolling both patients with limited and extensive disease. And then they're going to try to parse those two groups out and try to see what the benefit of PCI is in the modern era where we have very good MRI imaging and stereotactic radiosurgery capabilities. But we just don't know. And again, I'll tell you, my bias is that if cancer comes back, it's really hard to get it to go away again for good. And so preventing cancer coming back is generally wise. But the challenge has been mentioned is PCI has all sorts of side effects. It definitely affects people's memory. It can affect executive function. It depends on the age too. Because I have a lot of patients who got treated in their 40s and they seem to be okay. But patients who are treated in their 70s, for example, have a lot more challenges. So it's a difficult conversation. So when I talk to patients, I try to be very blunt and list the pros and the cons, and then kind of get a sense of what the patient's priority is and what makes most sense given the circumstances and chart a path forward. But definitely PCI is the trickiest part of the treatment of small cell lung cancer, and I'll admit it.
I was limited stage and I was about 60 when I had it done.
Well, thank you. Yep, and I remember that information coming out because in 2006, I think it was 2007, right after I finished my chemo, and I did do the PCI. But thank you.
Hello. Hi, thank you for putting this together. I'm logged in at like 5 in the morning here, but I actually have a really quick question. My father is 77 years old, and he was diagnosed last September with extensive SCLC. His brain scan that was done, an MRI that was done in September came out clear, and all his subsequent PET scans came out clear after 9 cycles, actually, or 6 cycles of carboplatin, etoposide, and Tecentriq. However, we had one brain MRI with contrast done 3 days ago where it showed some lesions in his brain. And give me one quick second so I can read out what it says. So it says multiple variable sized peripherally enhancing lesions are seen in the bilateral frontal and other areas of the brain as well. The largest lesion is about 2 inches by 2 centimeter by 1.3 centimeter in his frontal lobe. So that's what it came out with. We're going to be meeting our radiation or radiologist today. So I want to prepare myself. Like there are certain questions that I have, and this is very timely that I'm talking to you. Like we're meeting them in the next 4 hours. So I wanted to ask you, like, given my father's age, he's 77 years old, and like I'm not quite sure if if we can actually do a gamma knife because there are many lesions that they've found, or is that a possibility? Also, if we suggest something like, whole brain radiation sparing hippocampus, is that even a possibility?
Yes. Well, first of all, I'm sorry to hear that the cancer has spread to the brain,
Thank you.
and that's challenging. So there's a few things there. So depending upon how many lesions there are, that would dictate whether radiosurgery is feasible and appropriate, or if somebody needs whole brain radiation. And we don't know exactly what that number should be in terms of when you should choose one versus the other. In physicians who treat a lot of brain metastases, like at the Brain Tumor Center, generally they would say if there's more than 5 to 10 in small cell lung cancer, you probably should do whole brain radiation. But I will say in the United States, there's a lot of good radiation oncologists that try to maximize radiosurgery as much as possible and would treat many more than that to try to avoid the toxicity of whole brain radiation. But if whole brain radiation is necessary, there's two things that you can do to limit the side effects of the treatment. So one is do hippocampal avoidance, and that's feasible if there are not tumors near the hippocampus. If there's a tumor right in the hippocampus, then that's not feasible. And basically the hippocampus plays an important role in memory development, and it stays active, and it's a very, what's the right word, evolving part of the brain. So even as we age, the hippocampus continues to evolve, and so you want to try to spare that. The other thing is a medicine called memantine. Memantine, M-E-M-A-N as in Nancy, T-I-N as in Nancy, E, memantine. That's a medicine that we generally give when we do hippocampal avoidance. It's a medicine that's used in dementia and other neurological conditions, and patients begin memantine on the first day of their whole brain radiation, and they continue it for 6 months. And that's been shown to provide some protection to the brain from radiation therapy. So if whole brain radiation is necessary, then hippocampal avoidance and memantine are the two things that have shown benefit.
I have a question. In late November of last year, I was diagnosed with stage 4, and I've gone through the chemo. I've gone through the 10 treatments to my lungs, showed up in my brain twice. I just recently completed my second hippo. What is it? Hippo.
Yeah, the whole brain.
But I still have 2 spots in my lungs. One is
0.3 centimeters.
Yeah.
And 0.5 centimeters.
And I'm on immunotherapy. So am I considered to be, I don't know, almost in remission with the spots on my lung? I mean, they shrunk drastically, but they haven't gone away.
And those small spots, 0.3 and 0.5 centimeters, I presume they were larger before you started chemo and they've shrunk to that point?
They were drastically larger.
Yeah. So it's not uncommon for scar tissue to be left behind when tumors shrink in the lung. We see it in essentially everybody after radiation, and in many patients even after chemotherapy. And there's 2 ways to determine if it's scar tissue or if it's active cancer. And both of them require a little patience because, well, the first is just following with CT scans, because if it doesn't grow over time, we know that it is just scar tissue. The second is a PET scan. Now, the problem is a PET scan requires a certain number of cancer cells to be in a tumor to generate enough signal to glow. And basically, you need about 8 to 10 millimeters, so 0.8 to 1 centimeter tumor nodule to be big enough to light up on a PET scan. So the good news for you is that those tumors are super small. The bad news is they're too small for PET scans to be helpful. And so in your circumstance, we would say, this is great. These are tiny little nodules. Let's just keep an eye on them and see what happens. And if they grow down the road and they're the only sites that are growing, sometimes we would treat those with radiation. There's other ways we can treat them, but generally if something's that tiny, we would just watch it.
I was diagnosed in December with extensive small cell, never smoked. It was like super fit, running OCR races and tournaments and everything. The only way they found it was I was having severe spasms through my torso. And so I had a tumor in my left lung and lesions up my spine and 2 of the lymph nodes. One of the spasms has been the ongoing issue. I finished the 4 rounds of chemo and immunotherapy. This week I have my 2nd round of immunotherapy. I had 10 sessions of radiation on the tumor. Now, when I started chemo, the very next day, the spasms stopped, but now they have returned now, and we're not sure if we're assuming that maybe it was the steroid maybe that stopped them, but they're an ongoing issue. They can be mild to extremely painful, like drop on the floor, so painful. And I haven't been able to get anyone to figure it out. I don't know if it's one of these peculiar things of small cell, or if it's, I've been tested for the paraneoplastic syndromes. I've had several blood tests for that. They've all come back negative. So if you have any insight.
Well, it sounds like a lot of bright minds have been tackling this. So I'm not sure how much I can add, but where is the spasms originating again?
So when I first started having any kind of symptoms was in my jaw, and I went through all the dental endodontists, all of that. They couldn't find anything. And then like 2 months later, I was a CrossFit person. I was doing, a high intensity workout, and I started to have spasms in the middle of my back. And I was like, oh, I must have injured my back. But when they would go away, I'd be okay. But every time I would do a high intensity workout, they would happen and they would get more severe. And as I came closer to my diagnosis, every morning I would have an episode where they would bounce around. They might start in my neck, they'd go to my arm, they'd go to my ribs, they'd go through my back. It usually ended up in my hip joints, which was the worst, and down my thighs.
I guess 2 things. Number 1, your symptoms do not indicate that it's coming from a localized area. That is to say, if somebody's having spasms always in the same spot, you would think, oh, there's got to be something associated with that part of the body. Is there a nerve that's impinged? Is there a muscle that's irritated? But the fact that they're migratory suggests that it's a more systemic thing, like a metabolic problem, whether it's an electrolyte abnormality, some rare paraneoplastic syndrome that we don't even know about because we tested for all the ones that we know, but maybe there's one we don't even know about that could be contributing to that. So I'm not sure I know the answer, but it definitely be something more systemic rather than a local tumor, for example. My other question is, and this brings up an interesting point that comes up in our tumor board. So we had a thoracic pathologist who basically said to us, if a never smoker is diagnosed with small cell, I want to see that pathology because I want to be 100% sure this is small cell. I've definitely had never smokers get small cell, but it's super rare. I assume that you've had like your pathology reviewed by an academic pathologist for a second opinion, just to make sure that this is exactly what it is.
Yeah, we did. Yeah.
And I have a couple of questions in the chat. One, this person says, my mother has tumors in the lung and chest. Oncologist said that radiation is not an option because of COPD and fibrosis. Can chemo, carboplatin, and etoposide suffice to go into some sort of remission?
The answer is yes. So some patients, depending upon their lung function, might not be good candidates for radiation therapy if trying to treat all of the sites of the disease would just involve too much of the lung. So when we treat cancers in the lung, we treat the cancer, but the lung in the immediate vicinity can also be affected. And so if that amount of lung is excessive, then we'll say, okay, maybe we'll use radiation down the road, but let's start with some chemotherapy and shrink the disease. And then either we could use radiation to treat a smaller tumor, which may be associated with less side effects because the radiation field size is drastically smaller, less normal lung in the radiation field. Or in some circumstances, we would say, let's start with some chemotherapy and use radiation for lesions that don't go completely away. So you kind of customize the radiation based on the circumstances. But I think in that circumstance, if the doctor said, you know what, this is just too large of an area or too many tumors to treat with radiation, it'd be totally appropriate to start with chemotherapy and then reassess.
Another question in the chat: how hard should I push for twice a day radiation? I am 60 years old with limited small cell lung cancer protocol. The same, just 6 weeks radiation once a day. Should I ask for the 7 weeks?
Well, I think it's always good to have a discussion with the radiation oncologist to get their thoughts. There's a lot of different opinions out there. There's not just one way of doing things. Many really good radiation oncologists who treat small cell lung cancer at big academic centers prefer once a day radiation, and some do it 6 weeks, some do 7 weeks. So anywhere between 6 and 7 is reasonable. I think my preference has been to do twice a day radiation because 2 of the 3 studies, even though there's some nuances and there's some limitations and it's hard to interpret some studies based in that were done a couple decades ago, but I like the twice a day. So if that's something you want to learn more about and get the opinion of your local radiation oncologist, just talk to them and see what they think.
Another question: can the same site receive a radiation series more than once? If it can, how much time in between?
That's a very good question. So it depends on a whole lot of factors. It depends on what dose of radiation a tumor received or a site received the first time around. That will that will dictate how much more you can give it down the road. It depends on the time interval between 2 treatments. So if there's 3 months, that's going to be very hard. If there's 10 years, very easy to give radiation again. So the bottom line is that with our modern radiation delivery mechanisms, most areas we can give some additional radiation if we need to. But sometimes we will get up to a point where further radiation is just associated with too many risks.
I have a couple of questions if we have time that somebody sent in, but I know that wants to comment on something.
Hi. Talked about these spasms. That's how my small cell lung cancer was diagnosed. I had spasms back here, and then the next morning when I woke up, it was like there was a vice around my throat all the way down to the middle of my chest. I couldn't breathe, I couldn't walk, and I had been, paddleboarding and kayaking and doing all sorts of, aerobic things, 2 days earlier, and I couldn't even move. And I had low sodium, and that's what was causing that cramping. I don't know, I know Dr. Kelsey said that it's probably an electrolyte thing, so that sort of holds water for that. And the non-smoking, I was a non-smoker. And I did have 2 pathologies done. And because my oncologist here said it was unbelievable to have a, healthy woman develop this. And they did all sorts of genetics. They did everything. And my radiation oncologist said he's like 90 to 100% sure that it's from radiation I had over 30 years ago for breast cancer because the radiation was so strong back then. And so, I would like to see them start following up on these women that had radiation. It was prophylactically. I shy away from prophylactic radiation now, so I chose not to do the whole brain. But yeah, that's what they're saying it was caused by. So it does happen.
Yeah, and I can comment on that. So I'm involved in a number of endeavors where we're looking at patients who get thoracic tumors after receiving treatment for breast cancer, lymphoma, and it happens. It's quite rare, but it happens. And if a tumor develops right in the radiation field, then we know that the radiation is probably the contributing factor. And sometimes we'll see patients where the tumor is far outside the radiation field, and in those circumstances, we think probably something else happened. But yeah, both radiation and chemotherapy, ironically enough, can cause cancers. It's sort of this huge irony of our field that the very treatments that we give people to cure cancers can cause cancers, because both radiation and chemotherapy damage the DNA of cancer cells and cause them to die. But they can also damage the DNA of normal cells that survive, and then 30 years later will turn into cancer. So I can sympathize with that story. So I'm sorry to hear that.
Somebody raising their hand. Okay, go ahead.
I had breast cancer 12 years ago, right side, and that's where everything is. And my lungs always been sore there, but
You were radiated.
what? I was radiated.
I had the opposite problem. I had to get mammograms more before the typical age because of the radiation to my chest.
Right.
Then put me at risk for breast cancer. But let me ask these. One question somebody sent in, can CBD be taken along radiotherapy? If not, how soon after the radiotherapy is completed can CBD be used?
I don't think I have a scientific study to back up my statement here, but the answer is I don't think it's going to make a big difference. The one thing that patients shouldn't take while they're getting radiation is high doses of antioxidants. So not just a multivitamin, but taking 3,000 recommended daily allowance of vitamin C and vitamin E, for example. And there's been some studies, not in lung cancer, but in other cancers, that show that taking high doses of antioxidants during radiation and chemotherapy treatments can make those treatments less effective. So I wouldn't class CBD oil in that category, but it's good to remember that antioxidants may not be all that good while you're getting radiation treatment.
Okay. And this might answer this next question then. So are there any particular natural supplements like green tea, e.g. CG, curcumin, that should be avoided during the treatment?
Right. So, this may sound super simple, but sometimes it's the small and simple things that make the biggest difference in life. I generally tell patients, look, what I really want you to do is get some exercise every day, even if it's just going for a short walk, get as good a night's sleep as you can, eat a balanced diet, and show up for your cancer treatments. And if you do those things, you're going to be setting yourself up for success. Whether or not a lot of other things are beneficial, for the most part, we just don't know. But we know that those three things are good for your life anyway.
Good. Yep. And what can an elderly patient do to minimize radiation side effects?
That's a good question. So to a grand extent, there's not a whole lot of things that patients themselves can do to mitigate the side effects of radiation, to be really honest with you. It really behooves the radiation oncologist to put together the best plan possible, both in terms of how much radiation to give, whether to give it or not, et cetera, and then to do very careful radiation treatment planning so that the radiation targets the tumor but minimizes the dose to everything else. That's really where the money is. So I wish that patients had more power in this regard, but for the most part, you just need a good radiation oncologist.
Good. And one more question. I think you you answered this, but I guess you could summarize it again. If there are any residual tumors left after full course of radiotherapy, would a second set be recommended?
Yeah, so the challenging thing when we treat lung cancer, and this is true for both non-small cell and small cell, is that after, for example, thoracic radiation, there's always scar tissue that gets left behind. And it can be very challenging in the short run to know whether that scar tissue is scar tissue or if there may be some cancer cells hiding out. And there's basically two ways, well, I guess there's three ways to evaluate that. One is to follow with serial CT scans, and that's by far the most common thing that we do. The second thing that you can do is get a PET scan. The problem with PET scans is there's false positives. You can have inflammation from the cancer treatment that's lingering that can light up. And so not everything that lights up is cancer. So sometimes you have to read PET scans with a grain of salt. And then the third thing that you could do is a biopsy. The problem with biopsies is it's invasive. And let's say you do a biopsy and the pathologist sees some abnormal cells. Oftentimes we don't know, is that actual cancer cells that are still viable and able to grow and spread, or are they just dead cells that are still visible? So for the vast majority of patients after a course of radiation, as long as the tumor is shrinking and stabilizing on CT scans, we're good. If it grows at some point down the road, that's when we would get a PET scan. And if it looks suspicious, then sometimes get a biopsy to prove it. But for the most part, we just need to be patient and follow it on scans.
Thank you so much. Thank you for your time. Thank you. We
bet.
really appreciate it.